Hello, I'm Dr. Shivakumar Vignesh from the Moffitt Cancer Center and the University of South Florida College of Medicine. I've been asked by the DDW administration to submit a video abstract of our study titled Safety of Endoscopic Procedures in Patients with Severe Thrombocytopenia. I am the lead author of this study, and my co-authors are Deepthi Kanchi, Jill Weber, Bhupendra Raval from the Moffitt Cancer Center. Working at a major cancer center with a large hematological malignancies program, we're frequently faced with the decision about performing endoscopic procedures in patients with severe thrombocytopenia. Severe thrombocytopenia is defined as a platelet count under 50,000 per microliter. It is generally accepted that endoscopic procedures can be safely performed with a platelet count over 50,000 per microliter. However, there is no evidence in the GI literature regarding the safety or utility of performing endoscopic procedures when the platelet count is under 50,000. There's a strong clinical need for performing both diagnostic and therapeutic endoscopic procedures in patients with severe thrombocytopenia. The common reason is to evaluate GI symptoms in patients who have undergone bone marrow transplantation or who are receiving chemotherapy for hematological malignancies. The other indication is patients with gastrointestinal bleeding that persist despite platelet transfusions. The main question we set out to answer was the complication rate of endoscopy in the setting of severe thrombocytopenia. Platelet transfusions are also frequently administered prior to procedures in this setting. Now I would like to talk to you about the methodology. We conducted a retrospective cohort study of all endoscopic procedures performed in the setting of severe thrombocytopenia over an 8-year period at Moffitt Cancer Center. A total of 232 patients fit these criteria. It should be noted that none of the patients had known coagulopathy or other disorders of coagulation. We reviewed patient demographics, comorbidities, medications, and the patient's course was followed for 30 days after endoscopy. Post-procedure bleeding was defined as any documented GI bleeding occurring within 30 days of the procedure. Significant bleeding was defined as a hemoglobin drop of greater than 2 grams per deciliter. Platelet count was documented a week prior to the procedure, on the day of the procedure, and a week after the procedure. Transfusions were clearly documented regarding the type of transfusion, the number of units transfused, and the timing of the transfusion in relation to the procedure. 2 statisticians independently conducted the analysis and verified the results to confirm accuracy. Multivariate logistic regression was used to study the relationship between variables and post-procedure bleeding. There was a statistically significant association between moderate and severe chronic renal disease and post-procedure bleeding. The adjusted odds ratio, which takes into account confounding factors, indicated that the risk of post-procedure bleeding was greater than 4 times normal in patients with severe renal disease in the setting of thrombocytopenia. Normal endoscopy, or endoscopy negative for a lesion to explain bleeding, was significantly associated with post-procedure bleeding with an adjusted odds ratio of approximately 3. Coming to the conclusions of our study. From our study, it is clear that endoscopic procedures with mucosal biopsies may be safely performed in patients with severe thrombocytopenia. The risk of significant bleeding in this population was 1.7%. This is quite a low number. However, it must be noted that it is relatively higher compared to the risk of bleeding in the general population. Multiple mucosal biopsies may be safely performed. However, other endoscopic interventions have to be carefully considered as they have not been studied in this setting. Pre-procedure platelet count or platelet transfusions did not have an impact on the risk of post-procedure bleeding. Concomitant use of platelet inhibitors did not affect post-procedure bleeding. The only clinical variable that was significantly associated with post-procedure bleeding was moderate and severe chronic renal disease. This is not surprising, as it is well known that platelet dysfunction is associated with moderate and severe chronic renal disease. This may be the population to avoid endoscopy in the setting of severe thrombocytopenia. This study will impact many patients with severe thrombocytopenia who are referred for endoscopic evaluation. It fills an evidence void in a very important area of endoscopy and will help formulate evidence-based guidelines regarding the safety of endoscopy in this setting. Thank you.